Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dall Simons Family Studio. Delighted to be back with you to this program, Open Mics with Dr. Stites. You can find me here every Wednesday talking about all things COVID as well as other topics. We're really hoping someday we don't have to talk so much about COVID, but right now, it's still top of mind. Today, we have a special guest joining us to talk about a new study regarding lymphoma patients. In this studio with me this morning is Dr. Joe McGuirk. He is the director of the Hematologic, Malignancies, and Cellular Therapeutics and medical director of Blood and Marrow Transplant. That's a lot of words. Joe's one heck of a hot BMT doc. That's what we like to say. I've known him for a long time. If you ever have that kind of cancer, this is the guy you want to see. We will talk more with Dr. McGuirk soon, but first, let's go to our good friend, Dr. Dana Hawkinson, Hawkeye, Medical Director of Infection Prevention and Control, to share our COVID-19 inpatient numbers for overnight.
Yeah.
Hawk, how are we doing?
You know, our numbers have increased.
They drifted up.
That high to mid-30s kind of have gone up a little bit. 40 active patients with 13 in the ICU, 9 on the ventilator, and 16 in that recovery period. So a total of 56. Hays still does have 8 total patients with 7 active and 1 in that recovery period. So the numbers for hospitalization are creeping up, and I was talking with a friend last night about this. You know, we do understand, and we've said this now for a few months, about testing. I think we probably have to assume there's 5 to 10 times more of the actual cases, and just like you had said, you know, starting a couple months ago, the real bellwether is going to be hospitalizations, and we are seeing hospitalizations creep up.
And we're seeing them increase at a time when hospitals are full. I was looking at some numbers this morning about the percentage of high occupancy, which means it's hard to get into the hospitals, in our region. And in June, it was like 0. In May, it was like, 1,000 hours were like that. And in July, it was like 3,000 hours were like that. And what that just says to you is how full our hospitals are, in part because we're about 400 COVID patients hospitalized in Kansas City right now in our metropolitan area, the Core 4. So that's tough. At the height of the pandemic, we got up to just a little over 600. We're not as high as we were then. But remember this. The curves we're seeing today are lagging behind hospitalizations. I'm sorry, the hospitalizations lag behind the curve. So we are at the highest point of new cases per day that we were since November. Now the problem with that is, because hospitalizations lag 2 weeks, we haven't peaked, and neither has that curve, and there are so many home tests being done, we're not even sure what it means to have a positive test because we don't have all that data. So I'm concerned. Also, Hawk, some stuff came out. I was reading in the New York Times this morning, the Wall Street Journal, all my great sources of medical information, but they do quote a lot of good studies, and it's a nice summary. This Delta variant thing, lots of younger people being sick, and not only are they getting sick, but they're coming in the ICU and some of them are dying. So the risks are much higher with the Delta variant, I think, for young people. Not clear if that's just because that's who's not vaccinated or because Delta actually does something to the young folks that the original strains did not.
Yeah, and I think for that science and medicine, I think we still need more studies on that. But to your point, I think it is probably the majority of those young people who are not vaccinated because they feel that individually they are going to be okay, but they are the ones out in those group gatherings doing those things that are more high-risk behaviors, so the overall numbers of young people are going to increase. And even if you have small percentages of people who have to go to the hospital, who have to go on the ventilator, if you have large total numbers of those people, those numbers of people who go to the hospital and those numbers of people, young people on the ventilators, are going to be greater, even for those small percentages.
They are. Other big news over today is that there's some preliminary data coming out of Washington. Multiple sources are saying the FDA will approve Pfizer's drug around the 1st of September. That looks like the date we're going to have an officially approved therapy. Hawk, what do you think? Is that too fast? Fast enough? What's your thought?
I don't think it's too fast. Again, I think what we have seen through the course of this pandemic with anything, whether you're looking at remdesivir, the monoclonal antibodies, the vaccines, is all of these steps have been done diligently and with thoughtfulness. The data has been analyzed, it has been collected, all the trials have gone on. It's just been expedited in the way that they've done it. So no, I don't think it's too soon.
I don't think it is either, and I'm going to ask Dr. Joe McGuirk the same thing in just a minute, because he's been through a lifetime of having to take new drugs on to patient populations, and I think it's really a critical question, and here's why. Let's take a look at this heat map for just a minute. You know, we keep going back to this. You can find it in the New York Times. See that deep purple purple zone and see where the river is right there. You can see kind of where that junction is between Kansas and Missouri. You can see what's happened with this heat map. We started showing this about 3 weeks ago. And remember, there's a small little nidus around Springfield. And now look at it. That area of purple is now encompassing a good part of Oklahoma, northwest Arkansas, Missouri, and now Kansas. And that purple area has grown up here. Johnson County is the only orange thing right around our core 4. On the Missouri side, it's all purple. And that is a lack of vaccination combined with a lot of increase in the number of cases and this hot spot that we're considered because we're at such high risk. How do we get out of that high risk situation? Only 2 things you can do. You can mask and you can vaccinate. And we know those are the ways for us to go ahead and stay safe. I think that this is really important with what the FDA is about to do with Pfizer. I think that is a game-changing moment. It'll be fully authorized. I think you'll see a lot of businesses and other places say, we're going to require vaccination. I think that's going to start happening sooner and sooner. And I think that's probably, in many ways, if we're going to protect ourselves as a society against the Delta variant as well as other variants, going to be the right thing to do. In addition, I think that they have not sped it too fast, and here's why. We've given over 1 billion doses of these drugs now worldwide. That is an amazing statement. There are very few other drugs, if any, that have had 1 billion times they've been given and studied across the world. And I think there has been a lot of focus on these medications and lots of reports of this side effect or that side effect that people had to go evaluate. And because there are so many people, we've been able to run down all those side effects. So I'm very confident that especially these messenger RNA drugs are going to be very safe. And just so you know, the FDA is playing fair. They went to Moderna and said, because Moderna submitted their data a few weeks after Pfizer, and said, guys, you need to give us more information than you've given us. So I think it's the FDA being diligent. And so as a result, it looks like Pfizer is going to be around September 1st. I'm going to expect Moderna is going to be about a month behind because the FDA said show us some more data. Dr. McGuirk, you've flowed through a lot of brand new drug therapies in your career in blood and marrow transplant. Give us a sense. Do you think the FDA is being careful enough?
Oh, I think the FDA is being extremely careful. That's their charge. I think they're very thorough. The tempo here of moving these drugs forward and protecting the population is really unprecedented historically, as you know. But this is not the only area where we're seeing this. This is a worldwide epidemic, and it's the fastest we've, I think, ever seen such a response at this magnitude. But we're seeing advances like this in cancer medicine too, not in the time frame that we have, but not too far off, 5 to 7 years to completely novel therapies, non-existent before, that are changing the landscape and the paradigm, the outcomes for our patients. So I think all of science is speeding up. I think the broadening of communication through the internet has facilitated a great deal of that. So the growth and the application of new therapeutic strategies is logarithmically increasing, not in a linear manner. And so it's stunning what we've been able to accomplish in infectious disease with these vaccines. I think we're more of this to come. I think there clearly has been a worldwide effort. The FDA has been absolutely key to those efforts in bringing these vaccines out for the population and getting the approvals, the emergency use authorizations, et cetera, and the upcoming approvals, as you mentioned already. So no, I think that people have been extremely meticulous and safe and careful about this. We've just been able to mobilize a great deal of forces to bring this to fruition.
I would just remind our listening audience that the FDA is the gold standard, but not only for the United States, really for the world. And everyone across the world looks to the Food and Drug Administration. We should be proud of that moment, that they look to us to see whether or not things are truly going to meet all the safety requirements. And I think, I think we're going to be there with Pfizer, and then later with Moderna, and then with J&J. Let's see if there are reporter questions on the line.
Hey, Dr. Stites. Good morning. Cody Holyoke, KMBC.
Good morning, Cody.
Hey. You've touched on a lot of things I was going to ask about, so I will ask you about testing numbers. Positivity rate in Missouri ticked down ever so slightly. 14.7% is still very high, and I didn't know if that is good news or just a fluke from what you're seeing, but obviously, we see on the heat map that we're still not out of the woods yet. And then Dr. Hawkinson mentioned we have to assume there's 5 to 10 times more cases. If you could elaborate on that.
Yeah, you bet. So I'll take on this part, and then I'll let Hawkeye do that. And so here's what I think about the testing. Number one, if this is a trend that continues to go down, I'll feel good about it. Do I like it better than a tick up? You bet. Do I know what it really means yet? Yeah, probably not, and here's why. First of all, a lot of testing is done at home. Second of all, people may be deciding they don't want to get tested because they just assume they have the Delta variant. Third, some people just don't have enough access to testing, especially in counties where the numbers are really high, because they may just be further from a drugstore, they may be further from a place to go get tested. So if it continues, I'll be really glad. But I know the testing positivity in our area continues to go up.
Yeah, and I would agree. I think, again, it's speculation on my part, but it's speculation based on what we have seen in the past with the pandemic, with reports about other, spread of the disease throughout the pandemic, with estimates that, really the testing, there were a greater number of cases, there were actually a greater number of deaths. You can see this in different countries from studies, including India, UK, United States here. So it's more on that. It is more based on that. And, of course, what you said, Dr. Stites, with some people may just have it and don't want to go get tested because they feel they have it. There could be those asymptomatic cases where people aren't going around to get tested because they aren't having symptoms. There's a number of reasons for that. And so that's why I believe, we kind of have to assume, based on previously published reports from the last 18 months about the spread of the disease in whatever particular community or country, and then for what is going on right now, just with people may assume they have it, they don't want to go get tested, they may be asymptomatic. There are various reasons, and that is why I think we really need to use the hospitalizations, where people are actually coming in for care, to really judge what is the true impact of the disease at this point in time.
What you said, too, I think is really important. And we know this to be true from the Scottish data and from the Israeli data and from our own data. You can easily be positive once you're vaccinated and be completely asymptomatic. So you're not going to be prompted to go get a test. And so as in counties like, say, Johnson County, which has a little higher rate of vaccination, they may still have a high rate of being positive, but people will never know because they don't get tested because they're asymptomatic, but yet they can still spread the disease. So I think that's a concern.
But that's great, if they are vaccinated, because their chance of getting symptoms, or that whole spectrum of COVID-19 disease symptoms, is markedly reduced.
Yeah, I think that's right, and why we are encouraging everybody to wear a mask when they're indoors in public in public spaces now. So, other questions?
Hi, it's Dan Cohen over at Channel 41. I wanted to ask about Kansas and Missouri sharing vaccination data. I'm wondering if you've seen anything about residents jumping state lines potentially to get a third shot, since the states are tracking their own vaccination data for their own residents. I was curious to know if you had seen anything about that.
Yeah. I can't tell you that I've seen anything about it written. I've certainly heard about it from my patients, and I think that there is a little bit of that going on. And I think some people who are high risk, and like they may say they're status post-transplant or whatever, are looking at some of the international actions in Germany and Italy and other countries, not Israel and other countries, that are saying that, let's go get a third shot. So yeah, I know some of my patients have done that. I don't order those third shots because the EUA is very express about you can only do two vaccinations for Pfizer, Moderna, or one for J&J. But I do know people who are doing exactly that.
Yeah, and I've been answering questions like this for 2 weeks now about that. Again, the official guidance, and we do adhere to the official guidance, is that at this point in time, additional dosing or boosters is not needed. As far as tracking across state lines, I'm not even clear how well tracking is in the particular state.
I got to tell you, some of mine didn't have to jump state lines to do this.
And so, I think between private physicians' offices, private pharmacies, with the availability and supply that we have, because of that, I don't know that there's an ethical concern, because we do have so much supply. More ethical concerns are the number of people who aren't getting vaccinated. But again, I don't believe that there is really any good way to track that. And I was just talking with Dr. McGuirk as I came in. The other issue is, okay, so you're going to get extra dosing. Are you going to get dosed again with the Pfizer or Moderna vaccine, the mRNA that you've already had? or should you get dosed with the viral vector vaccine? Again, that is Johnson & Johnson that we have available in the United States, because some early studies do show that maybe you have a better B cell and T cell response if you're using that mixed dosing. It is very early studies, so again, that's why the guidance isn't there. We know that the FDA is looking at it. We know that the ACIP, that group that makes recommendations, is looking at that. So there are still a lot of questions to ask. If we do go get dosing, is it going to be safe? More than likely it will be safe. We still want the full data about that. But then, which one do you get? Because we just want to have maximal benefit if you are going to get additional dosing.
What are you saying to your folks? So, I mean, you have some of the most immunosuppressed patients on the planet, Dr. McGuirk. So what would you say about a third dose?
We do. In our transplant population, a significant percentage of patients will have little response or no response at all. We are seeing in a recent publication that Dr. Hawkinson and I spoke about this morning that it's somewhat better than we expected, that as many as 60% of our patients are having antibody responses and offering protection to them, but still that leaves 40% who are not. Our CAR T cells, which we'll be talking about here in just a moment, that population has even less of a response because the CAR T cells are designed to attack cells, B cells that make antibodies. And so what we're saying to our patients is best to pursue in the context of a clinical trial. And in that regard, we spoke yesterday as a team at our cancer center about amending a clinical trial that we have currently ongoing to look at antibody responses in transplant patients, in cancer patients broadly, but transplant patients as well. And we're going to send an amendment in to allow us to look at this question in the context of a clinical trial so we can answer some of the important questions that Dr. Hawkinson brought up with. What vaccine do you get? When do you give it? And to whom do you give it? If somebody has a suboptimal antibody response, and how do you judge that, or has no response at all, and those issues of timing. So there are a lot of unanswered questions. It's a really important and thoughtful set of questions about revaccination, third doses, booster vaccinations, and some of our patients after stem cell transplant, using somebody else as a donor. Mm-hmm. If that donor hasn't been vaccinated and our patient has been vaccinated before transplant, we destroy the patient's immune system, replace it with a foreign immune system that may or may not offer any protection. And so what do we do with those patients? Again, these important questions are best addressed in the context of clinical trials, which we're very invested in our institution.
And do a great job with. Okay, other reporter questions? All right, I want to get back over here to Dr. McGuirk on an incredible new standard of care for relapsed or refractory large B-cell lymphoma. That's a lot of big words for our audience to understand, so you're going to have to help us walk through that for just a moment. We became the third enrolling site in the world for a study on kite CAR T. This sounds like something you'd fly. Obviously, that's not what the case is. So talk to us about, first, Dr. McGuirk, what's so groundbreaking about this new therapy? And talk to us a little bit about what is this large B-cell lymphoma thing?
So large B-cell lymphoma is the most common form of non-Hodgkin's lymphoma in adults in the United States and actually in the world community. It is a cancer of immune cells, cells called B cells, and B cells make antibodies. And so it's actually a cancer of our ability to respond to vaccinations. And these patients are very compromised. It's curable in a little bit over half of the patients, but half the patients are not cured with their initial therapy. They'll relapse or they don't go into remission in the first place. Historically, the outcomes for those patients were survivals at 2 years of about 15 to 16%. Stem cell transplant improved outcomes to about 30 to 35%, and that's been the standard of care for many years. However, we need to do better than that. 35% is not even close to good enough. And so one of the therapies that's unfolded is this chimeric antigen receptor modified T-cell population. What in the world is that?
It's a big word.
It is a big word,
And
yes.
somehow you got from chimeric with a C to kite, which I do like the kite thing. That's kind of cool.
Yes, right, absolutely. And so this big word basically, boiled down, means that the patient's immune system should prevent them from developing cancers in the first place, but it lets them down. Cells called T cells, part of the immune system as well. They not only fight infection, they recognize and attack cancers at their very inception. So most of us don't get these cancers. However, patients who do get these B-cell lymphomas, non-Hodgkin's lymphomas, the large cell lymphoma, the most common type, as I mentioned. When they do get these, their immune systems let them down. That's part of the story. And so CAR T cells are taking their immune cells, T cells, out of their blood to the laboratory, genetically reprogramming them to recognize the cancer and do the job that they failed to do in the first place, expanding them and taking them back to the clinic, infusing them like a blood transfusion into the patient. The cells sweep around the body, they attach to their cancer cells, they punch a hole in them, release molecules that go in and chop up the DNA, the chromosomes inside of the cell. It's really remarkable. And in the worst case scenario, patients who had a stem cell transplant but relapsed, or patients who were not candidates for a transplant because their disease was too aggressive, not responding to chemotherapy, for those patients, we saw response rates of 80%, complete remissions of 50%. And it became quickly approved by the Food and Drug Administration, as we were mentioning earlier. That was a very fast track, not as fast as our vaccines, but pretty darn fast in the realm of science and FDA approvals. That got approved, but it raised a question. Why should we wait until patients are in extreme circumstances like that, where their chance of being cured is in the long term is in the 10 to 15% range at 2 years? Let's move it up earlier. So at University of Kansas Health System, we involved ourselves with 2 large randomized trials. That's the standard of the standard measure of whether a new therapy is effective or more effective than the standard of care. 2 large randomized trials where we took hundreds of patients. Half of them got CAR T cells, half of them got a stem cell transplant, to see if we could change the paradigm and maybe stem cell transplant stays would be numbered. And that one of those prospective randomized trials has just reported out a significant improvement in complete remissions, the durability of those complete remissions, and something we call event-free survival, which means that they haven't relapsed, they haven't died from complications, highly significantly superior to stem cell transplant. That's a game changer. That's a paradigm shift in our field. And it means that more patients will not have to be submitted to the rigors of stem cell transplant. More patients will be cured up front. This will quickly become a standard of care treatment option. Not yet FDA approved, but on the fast track to FDA approval for patients in that situation. We were one of the lead enrolling sites in this worldwide study, multi-center, multinational trial that will be presented at the upcoming American Society of Hematology meeting in several months.
That is amazing. Now, just to say, I've been doing cystic fibrosis for like 30 plus years. I'm old. And, we have this new drug, Trikafta, and it helps about 80-85% of CF patients. And it's a complete game changer. I mean, people, you have to sit down and say, okay, this is a conversation I've never had with you. Because when I started CF, people died at 17, right?
Yeah, right.
Now they're living to be 40. And now we're saying to them, plan for retirement. I mean, you get tears in your eyes when you start. When people come back and they don't cough anymore, it's just so remarkable. I think, is this your moment?
Very
is this
similar.
your time
Absolutely.
when you get to say to people, you got to be thinking about retirement and how you're going to raise your kids and grandkids now, which
That's
is so
absolutely
different.
Right. Very, very different. Rather than talking about we're going to try to get you out a couple of years here, we're talking about curing these diseases.
And you're going to feel good.
That's absolutely right. That's right. You're going to feel good and have less chance of the late complications associated with stem cell transplant. I'm a stem cell transplanter. That's the way I was raised and bred. However, as new technology unfolds, we have to be willing to give up old technologies and move the ball down the field for our patients, and this does that. But we're going a step further. One of the important questions that many of the folks in the audience today may have is, well, the patient's T cells are dysfunctional. Not everybody's going into remission with your CAR T cells, McGuirk. How are you going to make it yet better than that?
We're going to blame you for that, by the way. Go ahead.
So one way to move the ball down the field there and make it better yet is to use a normal, healthy 18-year-old to donate T cells, make enough T cells, CAR T cells, for 500 patients rather than individualize it for the patient. These T cells have never been beaten up with chemotherapy, and the patients never had cancer, so they're more fit T cells. We have several studies in our system currently at the University of Kansas Health System where we're using third-party, more healthy CAR T cells with the hopes that will improve outcomes even further in terms of
And not a lot of
potential curative
rejection
therapy.
and stuff like that, because this is a different way of doing things. Talk to me a little
Absolutely.
bit
It's really an important question. If you use this 18-year-old's T cells in our patients, they're going to reject it right away, right? Or the T cells are going to attack our patient, cause something called graft-versus-host disease. And the answer is, with a new discovery that resulted in the awarding a Nobel Prize to 2 women this past October, Jennifer Doudna and Emmanuelle Charpentier, called CRISPR-Cas9, that allows us to very precisely genetically engineer T cells. That's allowed us to take this 18-year-old's T cells and edit out the molecules that would allow for rejection and edit out the molecules that would cause these T cells from the donor to attack our patient's tissues. So we make a CAR T cell, we make it so that it will survive and not be rejected and not cause harm in our patient. And as I mentioned, several such studies are currently underway in our center today.
You know, this CRISPR, these are all new languages, right, for all of us
Yes.
to talk to, for our audience to hear. CRISPR technology, and we're editing out the genes of 18-year-olds. I mean, these are amazing concepts that you and I never dreamed of when we went into medicine. You know,
Absolutely.
Hawkeye's cutting young, so maybe he was dreaming about it, but you and I did not. Is this the biggest moment of your career?
Absolutely. Unquestionably. I've been practicing hematology oncology and doing stem cell transplants for more than 30 years now. I've always been excited and optimistic about the future for our patients and their families and about our field, and enthralled with the science, but never in my career have I been as optimistic about the promising therapies that are unfolding in front of us. It's really, and this is corny to say, but it's true, it's gee whiz science, and it's resulting in improvement in patients' lives and their families. So it's an incredible time. It's the best time in the history of cancer therapeutics and probably in medicine to be a physician and get to be part of the story that's unfolding in front of us.
It is a golden age in medicine, so my story.
It is.
So I had a patient, and she was not doing very well from her CF, and got one of these new drugs, and her husband always fixed her coffee in the morning. And she would do her first treatment, and she had the vest, she put it on, she shake, rattle, and roll, and do the stuff that helps loosen up secretions. You cough it out, and then it takes about half an hour, but you cough about an hour, and even that's what a CF patient's life is like, and they do that several times a day. Yeah. So he's down making the coffee, and he's thinking to himself, well, I don't hear my wife. Well, what he hears is they're coughing every day, right? So she took the first dose the night before, guys, the night before she takes her first dose. He's worried she's passed out on the floor because he can't hear anything. Here's machine running, which the vest goes, but he doesn't. So he goes up to the steps. He hears the machine go off. He goes, oh, my, I got to get up there. He starts running up the steps. She's at the top of the stairs. He goes, I don't hear you. What's going on? She says, I don't have to cough. I don't have to cough. Okay, in the CF world, that brings tears to your eyes. Yeah. When you sit down and talk, to bring to my eyes, every time I tell a story, I start to get weepy. Have you had tears in your eyes as you talk to these patients about what's going on with CAR T?
Absolutely. Let me tell you a quick vignette.
Please.
An 18-year-old came to us with acute lymphoblastic leukemia, Bcell, acute lymphoblastic leukemia. She relapsed after her initial therapy. That can only be cured with a stem cell transplant historically. She couldn't have a stem cell transplant. Not only that, even if she could, we couldn't take her to stem cell transplant because we couldn't get her back into remission. So she was going to die, and she was going to die in a median of 3 months. We were going to lose her, this 18-year-old. She'd just gone into college to become a teacher. And she couldn't have a stem cell transplant even if we got her into remission because she's Jehovah's Witness. She couldn't receive the cells from somebody else. So we brought her in, we gave her CAR T cells, we took her T cells out, genetically engineered them in our laboratory to attack her cancer, brought her in, gave her those cells, she went into complete remission, she graduated from college, she's now a teacher, and we took her to a large national meeting, American Association of Cancer Institutes, and she told her story. She's not going to relapse, she's cured of her disease. If she was going to relapse, she would have done it several years ago. That's unheard of, that's remarkable.
Death, life.
Yes.
Science.
That's right.
You know, you talk to your patients, we've talked about this program for a long time. The combination of faith, hope, and science is powerful. But at some point, science delivers that to save someone's life.
Yes.
And of course, I want to draw the correlation to vaccination, which can save your life as well during this pandemic. But faith, hope, and science. And those stories abound.
Yes,
right?
that's
they
right.
abound, and I've got all these CF patients I follow, and they have that story. You have the folks you're following, they have that story. Grace abounds, love abounds, science abounds, and when that happens, life can abound. And I can't overstate enough what an important combination that is, and to think about where you've come from.
Yes, absolutely. Have you had a little more giddy up in your step? Oh, absolutely. Every day.
Makes you younger.
Yes, absolutely it does.
I wish it really made us younger. Are you going to cure that sometime soon?
I don't know about that. The clock is ticking fast for me right now, so we better get the show on the road with it.
Well, so you and I have worked together for a long time. I've been an ICU doctor up at the transplant ICU in my younger days, and you were here, and you and I would sit at those bedsides and look at those patients and look at the ventilator and look at the numbers, and I always admired how much you cared about your patients. And I just remember standing there with you, and I think, God, do we have to have this conversation again, meaning one about death and dying, and now you get to have a conversation about CAR T therapy.
Absolutely. And I do want to say, I just want to throw this out there, and I'm preaching to the converted here already, but our patients must be vaccinated. They absolutely must be vaccinated. We've lost 13 patients through the pandemic, 13 of our bone marrow transplant and CAR T cell patients to COVID pneumonia, and many of them won't respond to vaccination. We continue to recommend to them and all of our patients social distancing, wearing masks when they're in groups, and being very careful about avoiding crowds, and for goodness sakes, getting vaccinated, getting their family members, which for many of them is even more important in terms of protecting them, getting their family members, any caregivers vaccinated. It's so important. I talked about Sydney with acute lymphoblastic leukemia. We're talking about hundreds of thousands of lives, young lives too. One of the patients we lost was 23 years old on a ventilator in complete remission.
It just doesn't that. It just hurts your heart.
Yes, right, absolutely. And in complete remission, beat the cancer, and lost him to COVID.
This is so bad. And this is what hurts me on vaccination is that you see these people dying, and you're like, this just hurts my heart. You don't have to die, people.
Right.
You don't have to die. And you can say, well, the odds are low. Yeah, they're low until it's you, right? And then all of a sudden, what happened? Why didn't I get vaccinated? I mean, there's so much regret in the people's voices who are here who aren't vaccinated because they're like, oh, I should have been vaccinated. I can't tell you how many patients have said that to us. Hawkeye, how often have you heard that, the patients you see? I should have been vaccinated.
Yeah, I mean, it happens all the time. I think more heartbreaking was a nursing home patient I saw early on in the pandemic. When she asked me, what can you do to help me? And my response was, I couldn't do anything. And this would have probably been in March of last year when we know that it was raging through the nursing homes. And that was the most heartbreaking thing. But now we know we have these very good preventive measures, most, least of which is not the vaccination. So we need to get people vaccinated because we can save people from having to undergo that and having to ask the question when they're in the hospital.
And just for those of you who think that, and we're going to get to our community questions right after this, but I want to explain something about how the Food and Drug Administration works. So imagine, this is my arm span at 6 feet, imagine this is how much bandwidth the FDA has, okay? Every study they go through, they have to examine literally, truly hundreds of thousands of pages of documents. So they have staff designed to do that. But the average time is about 6 to 12 months to get a study through, usually about a year to be approved. What the FDA has said is, okay, for this pandemic, we're going to take our bandwidth instead of having a little bit of here, a little bit on CAR T, a little bit here on CF, a little bit here on pulmonary hypertension, a little bit on heart failure, a little bit on diabetes, a little bit on this, a little bit on that. What they've said is, we're going to take a bunch of our bandwidth and we're going to focus it right here. Which means to all these other diseases and the needs like CAR T therapy, they may be slower to get approved because they've taken their people and they've put all hands on deck over here on the pandemic. They're still going through the same 100,000 pages of information. That's why the FDA said to Moderna, you owe us more information. That's why they're saying to Pfizer, we're getting through all your information. So it's because they've reassigned people over here to do this. And by doing that, they're trying to get through the same amount of information they would have gotten through for a year. This is not a rushed FDA approval. It's the same process they always use. They're just putting more people on it. So don't get excited out there that somehow we're rushing these drugs, because we're not. What we're doing is we're focusing on the vaccination, sometimes to the detriment of other new medications, in order to get that FDA approval completed. Jess, let's see if there are questions from our viewers.
Hi, good morning. Yeah, Lilith has a question. She says, I suddenly had a significant drop in my total platelets, as well as white blood cells, red blood cells, and hemoglobin the week following her second Pfizer shot. Her doctors were alarmed. They did some tests. Everything was normal, and within 2 months, all of her counts were normal. She says she does take methotrexate and I don't know how to pronounce that one. But
Another drug.
You know that I don't use big words, but she wants to know.
Leflunomide, I'm sure. Yeah.
Leflunomide, yes, okay.
All right.
So could the vaccine have caused this drop in those blood levels?
Okay.
It's much more likely that the methotrexate caused the drop in blood levels, and the timing of checking the blood counts around the methotrexate was associated with proximity of methotrexate exposure. Now, the methotrexate very commonly decreases blood levels, and we have to adjust doses of it on that basis. Is it possible, theoretically possible, that a vaccination in and of itself could bring about a decrease in blood counts? Theoretically, it's possible. We haven't seen that in our patient population, and we have a very vulnerable patient population in terms of their blood counts, because they have blood cancers in the clinics where we take care of patients. And so theoretically possible. If it did occur, it is likely to be very, very transient. Much more commonly, though, when patients get viral infections, certainly COVID is not excluded from this at all. It will suppress the bone marrow, and it will suppress the blood counts and increase the risk for patients developing other secondary infections, and can do that quite significantly so. So very, very unlikely associated with a vaccination, theoretically possible, much more likely associated with the methotrexate, and when associated with either of those with drugs, almost always very transient or short-lived, but the virus can cause very significant and threatening decrease in blood counts.
And Dana, there have been a little bit of reports on that, some of that stuff with vaccination, but it's very temporary and not a very significant change. There was some early on stuff about that with platelets.
Yeah, I mean, we know that all the trials looked for that. We know that after the vaccines were rolled out, there were good systems and mechanisms in place to look at all of those types of things. And the overwhelming response to any of these side effects, whether it's low counts or the venous thromboembolism with low platelets or the myocarditis, the overwhelming consensus continues to be that the benefits of the vaccine much outweigh any of those risks, because they are such rare events.
And they're temporary, and they bounce back. I mean, even the myocarditis looks like it may affect some young people, but it tends to be very temporary.
Yeah.
And you know, it may be true with other vaccinations. We just never look too. So.
And if I could just comment on that too, you know, I had a discussion with a young 20-year-old patient with bone marrow failure that we did a transplant on, successfully doing well, very reluctant to have COVID vaccination, and I told him, I said, we have 57 patients over in the hospital right now with COVID. Many of them are on ventilators and such, and people are dying. And we've lost 13 of our transplant patients so far. I have never in our program admitted a patient because of a vaccination adverse event, and I'm not aware of any patient, certainly not on our service, who's been in the hospital necessitated because of a vaccination adverse event. So when you look at the risk-benefit ratio, I told them it's gigantic differential. In contrast to bone marrow transplant, where risk and benefit can be pretty close, there is a procedure. We're talking about astronomical differences in risk-benefit ratio.
Absolutely.
Jess?
All right, leflunomide. I'm never forgetting this word.
Yeah, good luck on that.
I know. Well, when people say you learn something new every day, I really do on this show. Okay, I got all these words, though. Marilee wants to know, what is the average length of hospital stay for those who are in the recovery phase?
You mean after they've had Delta, and how long are they here? Yeah, I think we're running about 13 days still. Do you know for
I was
sure?
going to say,
I believe that's about right.
Anywhere from 10 to 14 days.
Yeah,
I don't
I
think
think
we
it's
have
about 13.
good updated data on that. We haven't been keeping too close a track from the that recovered group as much as the active infections.
Yeah,
So.
we can go find that information actually, and my average length of stay I think is around 13 days. I'll verify that. In fact, I just looked at the dashboard this morning. I can't remember what it said. So,
but again,
I'll
a lot
find that
of
out.
times it can also be due to placement in facilities. It can be due to other medical issues that may or may not have been exacerbated by COVID-19. You know, there are a variety of reasons why they are still here.
Michael says, I would love to hear more explanation about shedding and spreading the virus.
Oh, that's my term, right?
Yeah.
The shed and spread event. Okay, so what that means is when you're infected with COVID, and especially the Delta variant, you start to shed the virus in your airway. And that's what happens with it. And then as you breathe out, you can spread it. And the problem is that even after vaccination, we think that people with that Delta variant, which is different than the original variant, can still shed the virus and they spread it. And the difference is that you still could do that post-vaccination, but you didn't get many of the viruses in your airway with the original strain, or even the alpha strain. But the delta strain is a little different, and so you still have a higher number of viruses in your airway, maybe not quite as many of those who are unvaccinated, but you still have a lot, and as a result you have an increased ability to spread it. We don't know the exact way to quantify that. You and I were talking about that yesterday and the day before. The Provincetown data out of Massachusetts is what the FDA is largely basing some of their information on, along with some information out of Israel and other countries. But the exact quantifying exactly how much risk you have is hard to do. We just know that it looks like it really exists because the virus was being spread at parties in which everybody was vaccinated in Provincetown. Anything?
Yeah, no, I agree. You know, a lot of this is based on conclusions that have drawn from very small studies. One study out of China looking at Delta virus in unvaccinated people showed that they had, you know, based on CT or cycle threshold values, the ability to detect the virus. They had maybe 1,000 times more viral replication in their upper respiratory tract. Now, what does that mean? Do you actually have infectious virus, or are you just picking up RNA for detection on that test? So that is unclear. The other part that they are looking at, just as you said, was the Provincetown, the MMWR report out of CDC, where they looked at all of those people who they thought could spread the disease and had actual cases. I think 75% or more of those people were vaccinated. So based on that body of work and probably some other unpublished stuff that they have, that is why they are saying we think that if you are vaccinated, you can just as easily spread the disease as if you are unvaccinated. But those questions still need to be fully answered. And I know that they are being investigated. It's just hard because to do studies and investigations on SARS-CoV-2, you need a biosafety lab, a Bcell-3, which they don't have many of those in the United States. So there's very few institutions that can do the research on that. But, you know, we will get more information on it and present it to you as we get it.
But by the way, shed and spread events are not new. That's how measles are spread. That's how chickenpox is spread. That's how the common cold is spread, rhinovirus. It's how lots of things are spread, shed and spread. So you shed the virus in your airway, whichever virus it may be, and you can spread it to others, which, by the way, is why masking is so darn important.
Shannon says, my husband has several autoimmune disorders and was on prednisone when he received his vaccine. Might his vaccine be less effective because of it?
You know, I think that is the area of concern. And
Yes.
Dr. McGuirk, you mentioned some of that within your population as well.
Yes, that's absolutely right. There are data in our population of patients that demonstrate if you are on steroids, your likelihood of having a robust and protective response to the vaccine is decreased. It doesn't mean that it's going to be non-existent, and for patients who are stuck on steroids for a long period of time, we recommend that they get vaccinated. We're increasingly able to check and see what their responses look like. The question about boosters, as the Food and Drug Administration looks at that, and we do the research studies we spoke about earlier, will help provide further guidance. But yes, it is possible. And so the recommendation that we would make to a patient on steroids for autoimmune disorders or our transplant patients is continue to social distance, continue to mask, make sure that your family members and your friends, your close acquaintances are vaccinated to help protect you, because you may not have an optimal response. And continue those safety measures.
And Hawk, you make the distinction a lot of time, B cell and T cell responses, et cetera.
Yeah.
You may still have a response to vaccination. It may not be as much robust as somebody who has a more normal immune system.
Yeah. Yeah, exactly. And we're still learning about what exactly that means. We've seen studies that show these antibody levels are higher than this antibody level. We don't know the exact level or the correlate of that protection of those antibodies. We see that there are studies saying, oh, your antibodies decrease or wane after amount of time, and Dr. McGuirk would be able to speak to this even better. But in the immunology, in natural infections, and we've talked about this before, this week and weeks past, that is what happens in natural infections. Your antibody levels do decrease. That is just what is the normal function. But the saving grace are those B cells that continue to circulate, that once you do encounter the virus again, they are brought into action very quickly to ramp up antibody production again. So.
If I could comment on that, there were studies of survivors of the 1918 great influenza pandemic and then subsequent smallpox before we eradicated smallpox, and who were now, a number of years ago, survivors at 90 years of age, 95 years of age. They could still detect memory B cells and T cells in those patients against the great influenza virus in 18 and against smallpox. So these B cell, memory B cells and T cells, as you point out, will persist potentially for the rest of your life, and when they get activated or exposed again, boom, they'll rev up and start making those antibodies again.
The body is pretty amazing. Come on, let's think about that. These people are almost like 100 years old, and they're still got those memory B cells.
And I think that's a great point to overall longevity of your immune system and the development of the immune system over generations and thousands of years. People were concerned about wearing a mask is going to decrease your immune system.
No.
But those types of vignettes and information kind of exactly go against that.
Yeah, wearing a mask is just a short-term thing. Just one more question.
Okay, so help Gene out with this one. He says, on Friday, I sat next to a person who tested positive for COVID yesterday. I'm vaccinated and have no symptoms. What should I do? Get tested? Quarantine?
That is a great question. We generally only go back 48 hours, Hawk. So this is 4 or 5 days. So I think we'd probably say, if you're worried, you can wear a mask. You can always go do a home test. But I don't feel real strongly about that one.
Yeah, exactly. I think that key is that 48 hours. Since the beginning of the pandemic, and I think even with Delta, we are considering really you can be infectious 1 to 2 days prior to any symptoms. So I think if it's beyond that, you should be okay. You're always welcome to go get tested. We know that new guidance for vaccinated people is if they are exposed, they can go get tested now 3 to 5 days after that exposure.
Final thoughts. I'm going to start with you, Dr. McGuirk. By the way, Dr. McGuirk is one of my heroes around here, and he's taking care of me too. So he is one of my he truly is one of my heroes around here.
That's a mutual feeling. My final thoughts are: it's an extraordinarily promising time in cancer medicine. CAR T cells and plus a whole lot more that are going on. Very, very promising time. Trust the science. The science around SARS-CoV-2 and COVID resulting COVID-19 is stunning. It's very solid. It's rigorous, as you described earlier. Trust it. It's not all about us as individuals. It's about our family members, about our neighbors, about our co-workers. We have a responsibility to each other. And if not for yourself, get vaccinated for others.
Yeah, and thank you. And thank you for all you do. And thank you for bringing this incredible message of hope onto this program today. Hawk.
Yeah, nothing to add. I think it was very well said. Thank you for coming on. It's always good to have somebody who can answer these questions, and we always look to you for knowledge, so thank you very much.
Yeah, I would say exactly that. Hope is a powerful medicine. It keeps many patients alive far beyond when you think they're going to, and sometimes it results in such these multitudes of small miracles that you see in patients because hope is so powerful. But hope needs an ally, and that ally is science, and the science can keep you safe. We'll be back tomorrow. Jessica Lavelle will be here with us. We're going to be looking at mental health concerns as children head back to school. Tomorrow morning, 8 a.m. We'll see you then.